Good morning. Am I audible? Hello, can you hear me? Hello, can you hear me? Hello, hello,
Check it online. Online only.
hello. Can you hear me? Hello, hello.
Good morning, everyone. Today I am going to present a seminar on examination of higher mental functions, and I'm moderator the answer.
To address something.
Hello, can you hear me? Hello? Am I?
Yes, sir.
Today we'll be covering about examinations of level of consciousness, orientation, attention, language, and memory. First of all, consciousness. Fish defined consciousness as a state of awareness of self and to the environment. To check consciousness, we'll use Glasgow Coma scale, which has three components: eye-opening response, verbal response, and motor response. Eye-opening response, we will see if the patient opens eyes spontaneously. That is given 4 points. Eye open to verbal command, speech, or to shout, 3 points. Eye open to pain, 2 points, and not opening eye is 1 point. Then verbal response, if the patient is oriented, it is 5 points. If there is confused conversation but able to answer question, then it is 4 points. Inappropriate response or a word dissemble, 3 points. Incomprehensible sounds, then 2 points, and no verbal response is 1 point. And to motor respond, if the patient obeys your commands for movement, then it is 6 points. Purposeful movement to painful stimulus is 5 points. Withdrawn to pain is 4. Abnormal flexion is 3 points, and extension is abnormal extension is 2 points, and no motor response is 1 point. So in minor brain injury, the total Glasgow Coma scale is 13 to 15. In moderate brain injury, it is 9 to 12, and in severe brain injury, it is 3 to 8 points. Now, orientation. Orientation refers to one's awareness to time, place, and person. When consciousness is disturbed, it affects the 3 aspects in the same order. When the customary events of passage of time are missing, it is very easy for the person to become more or less disoriented to time. So orientation to place is retained more easily because the surrounding provide the clues, and orientation to person is lost the last because the person themselves provide information which identifies. To check the orientation, we will ask the patient about time, place, and person in the same order, or we can simply ask these questions. Like for time, we can ask आज क्या दिन है, क्या तारीख है, कौन सा महीना चल रहा है, कौन सा साल चल रहा है, और अभी कौन सा मौसम चल रहा है. For place, we can simply ask आप कौन सी मंजिल पर हैं, कौन सी बिल्डिंग है, ये कौन सा शहर है, आप कौन से राज्य में हैं, आप कौन से देश में हैं. And for the person, we can ask आपका नाम क्या है, उम्र क्या है, आपके साथ कौन आए हैं, और आपका जन्मदिन कब आता है. फॉर सेंस ऑफ पैसेज ऑफ टाइम, वी कैन आस्क कि आप अस्पताल में कितने दिन से हैं, और आपके घर से अस्पताल आने में कितनी देर लगती. Now for attention, attention is the ability to attend to a specific stimulus without being distracted by extraneous, internal, or the environment stimulus. So to check attention, first observation, observe the patient. Check patient general attentiveness by observing patient's behavior and any evidence of distractibility. Then history, a patient himself will sometimes give history of difficulty in concentrating on work or on the routine task. Then tests that are used to check attention are digit repetition test. In digit repetition test, we will present digits. We will ask the patient to repeat the digits as we present to them. So digits are presented in normal tone of voice at the rate of 1 digit per second. Do not group the digits in pair like 2, 6, or 5, 9. Do not group digits in sequence that can be easily repeated like 2, 4, 6, 8. Continue till the patient fails to repeat all the numbers correctly. So we'll give them a sequence of numbers, and we will ask them to repeat the same. Scoring, a normal person can repeat 5 to 7 digits. If a person can repeat only up to 4 digits, then it is borderline or confused. And if a person can repeat 3 or less than 3 digits, then it is the attention is defective. For concentration, concentration is sustained attention. Sustained attention is known as concentration. It is the ability to maintain attention to a specific stimulus over an extended period. For attention, we can test attention by a random letter test or by serial subtraction. In a random letter test, we will present a series of random letters to the patient. Okay, and we will ask the patient to tap the desk whenever he or she hears the letter E. The letter should be read in normal tone with the rate of 1 letter per second. Then there is serial 7 subtraction test. This test is of limited validity because it is influenced by intellectual capability, education, calculating ability, and social economic status. So we'll ask the patient to do 100 minus 7, and we will do it until the patient fails to do so. For an illiterate person, we can simply ask the patient to say हमसफर को उल्टा बोल के बताइए, या फिर we will ask the patient कि हफ्ते में कितने दिन होते हैं, and we'll ask them कि इन्हें उल्टा बोल के बताइए. Third is language. The deficit in language system can lead to difficulty in assessment of cognitive factors such as verbal memory, proverb interpretation, and oral calculations. So a demonstration of a specific language disturbance is pathognomic of a brain dysfunction. So there are few definitions. What is dysarthria? It is a disorder of articulation in which the basic language is intact. Dysprosody is an interruption of the speech melody like tone, accent, or tempo. In apraxia, there is inability to perform skilled movement of face and speech musculature in presence of normal comprehension, muscle strength, and coordination. Then there is aphasia, which is a true language disturbance in which the patient demonstrates impaired production or comprehension of spoken language. Then there is dysphonia, which describes loss of volume caused by laryngeal disorders. And alexia is loss of ability to read in a previously literate person. And agraphia is acquired disturbance in writing. Now, causes of, first of all, we'll start with what, if the patient is dysarthric, what are the causes of dysarthria? There can be a localized lesion in tongue, lips, or mouth. There can be ill-fitting dentures, or there can be lesion in the upper motor neurons or lower motor neurons. There can be lesion in cerebellum, or there can be lesion in extrapyramidal system or in nerve, muscle, or in the neuromuscular junction. So there are various types of dysarthria. There can be flaccid dysarthria, spastic dysarthria, hypokinetic dysarthria, and ataxic dysarthria. In flaccid dysarthria, which is a kind of it is a lower motor neuron lesion in which there is weakness of muscle supplied by 7th, 9th, 10th, and 12th nerve. So apart from dysarthria, we will also get dysphagia, absence of gag reflex, absence of jaw reflex, palatal weakness due to which there will be nasal voice, and tongue wasted and prone into fasciculations. And in spastic dysarthria or pseudobulbar palsy, there is bilateral upper motor neuron lesion. So the speech will be slow, harsh, strangulated with difficulty in pronouncing consonants. The jaw jerk will be brisk, tongue will be contracted and stiff, and there will be emotional lability. Then ataxic dysarthria, this is seen in cerebellar lesions. The speech will be slow, slurred speech similar to alcohol intoxication. Along with this slow, slurred speech, there will be nystagmus and there will be cerebellar gait. And in hypokinetic dysarthria, as seen in Parkinsonism, there will be low volume, monotonous voice, words running into each other, and marked stuttering or hesitation. Then aphasia. Aphasia is true language disturbance in which there is disturbance in comprehension or production of spoken or written language. To test aphasia, we will test fluency, comprehension, naming, and repetition. First of all, observe patient's spontaneous speech. Listen to patient's spontaneous speech, and or ask the patient open-ended questions like अपने गांव के बारे में बताइए or something like that, and observe if the speech output is present, or if the speech is dysarthric or prosodic, or if there are any word-finding pauses, abnormal words, or paraphrases. If the speech output is totally absent, that means there can be severe dysarthria, there can be apraxia, or there can be a true language aphasia. Now check for fluency. To check for fluency, fluency is the ability to produce spontaneous speech fluently without undue word-finding pauses or failures in word searching. To check for fluency, we have two tests. One is animal naming test, and second is fluency is the ability to produce spontaneous speech fluently without any undue word-finding pauses or failures in word searching. To check for fluency, we have animal naming test and FAS test. In animal naming test, we will ask the patient to name as many animals as possible in 60 seconds. So a normal individual can produce around 18 to 22 animal names plus minus 5 in 60 seconds. In age less than 70, score less than 13 is impaired fluency, and in age less than 80, score less than 10 is considered as impaired verbal fluency. Second is FAS test. In this test, we will ask the patient to say as many words as possible, starting with F, A, and S for 60 seconds each. But the words should not be the names of the person. In normal individual, 36 to 60 words are produced in 60 seconds. If the words are less than equals to 12, that indicate reduced verbal fluency. Then comprehension. Comprehension is to understand verbal input. So to check comprehension, we have two tests: pointing command and series of simple and complex questions. In pointing command, we will ask the patient to point to single objects in the room, body parts, or article collected from examiner pocket. For example, we will ask the patient to point towards fan or over pencil or keys. Increase the number of objects until the patient consistently takes. The patient of average intelligence without any aphasia should succeed to pointing 4 or more objects. Second is series of simple and complex question. The question should have either yes or no as answer. For example, is this a hotel, or is it raining today, or do you eat breakfast for dinner? Always ask 7 questions, because correct response can occur by chance in 50% of the cases, and correct answer correct answer should alternate between yes and no randomly, because the tendency of the brain damage there is a tendency for the brain damaged people to perceive it. Then is repetition. Repetition is a complex process that can be affected by impaired auditory processing, disturbed speech production, or disconnection between repetitive and expressive language functions. To check for repetition, we will ask the patient to repeat the word sentences or verbatim after the exam. For example, we will ask the patient to repeat these words, starting from simple words and going to complex sentences. Normal people and brain damaged patients without aphasia can accurately repeat up to 19 syllables. Naming in naming, we'll do a confrontation naming test. We'll point to a variety of objects and ask the patient to name them. We will start from like simple words. We will start from for example, from color, then parts of the body, then things in the object, and then part of the object. First, we will use common items like high frequency items, which I use daily, and then we'll use some uncommon items like low frequency items. Patient will recognize the object in naming. In patient who have naming problem will recognize the object and will be able to demonstrate and describe its use, but cannot name it. For example, a patient shown a door key respond with, "Oh, you know the thing used to get in. You turn it to get in," but he will not be able to name it as key. A normal low frequency words will be frequently misnamed. Low frequency words like parts of the objects will be frequently misnamed by normal patients as well as in patients with early dementia. So there are various aphasias. First is Wernicke's aphasia. In Wernicke's aphasia, the problem is in the Wernicke's area number 22, which is in the superior temporal gyrus. So this area is responsible for comprehension. So in Wernicke's aphasia, there will be impaired comprehension. However, because Broca's area is intact, so fluency will be preserved. There will be impaired repetition. There will be impaired repetition, and naming will be impaired. For naming, we require and Broca's aphasia. Broca's aphasia, Broca's area is area number 44 and 45 in inferior frontal gyrus. This area is responsible for fluency, and if this area is damaged, then fluency will be impaired, comprehension will be preserved, repetition will be impaired, and naming will be. In conduction aphasia, the arcade fasciculus which connect Wernicke's area to Broca's area will be impaired. So in conduction aphasia, there will be preserved fluency, preserved comprehension. However, there will be impaired naming and impaired repetition. Next is memory. Memory is a general term for mental process that allows the individual to store information for later recall. So human memory has we have three types: sensory memory, short-term memory or working memory, and long-term memory. Sensory memory lasts for less than 1 second. Short-term memory lasts for less than 1 minute. And long-term memory lasts lifetime. And long-term memory is again divided into explicit memory and implicit memory. Explicit memory is declarative memory, which are facts and events, which can again be divided into episodic memory and semantic memory. Episodic memory is about events that and semantic memory about facts and concepts. And another long-term memory is implicit memory, which is also procedural memory. Clinically, we divide memory into immediate memory, recent memory, and remote memory. Things to keep in mind before clinical memory evaluation is that the patient should have a sustained attention. Inattentive, distractible patient cannot perform optimally on such test. To check for immediate memory, we'll use the same digit repetition test that we use to check attention. For recent memory is the ability to learn new material and to retrieve that material after an interval of minutes, hours, or days. Orientation to place and time are actually measures of recent memory, as they test patients' ability to learn these continuously changing facts. So for recent memory, we can check the patient's orientation to place and time. Firstly, we can ask him about his name, age, and date of birth. We can secondly then the place where he is currently residing in terms of name of the place, kind of the place, floor, city, state, country, and his home address. And lastly, the time domain comprising of date, time, season, or year. Or simply we can just ask the patient these questions like कल रात को आपने क्या खाना खाया, आज सुबह आपने नाश्ते में क्या खाया, इस महीने का क्या नाम है, या फिर आज कौन सा दिन है. Scoring. Normal people score perfectly on all three domains. A person who are not high school educated can make a mistake of ±2 in recalling the date, and person who are above high school educated can make a mistake of ±1 in recalling the date. Then remote memory. To test remote these tests evaluate the patient's ability to recall personal and historic event. So we can ask the patient about आपकी उम्र कितनी है, आपका जन्म कहाँ हुआ था, आपकी शादी कब हुई थी, आपकी नौकरी या व्यवसाय करना, आपने नौकरी या व्यवसाय करना कब से चालू किया. Then last is new learning ability. New learning ability, to check new learning ability, we'll tell the patient 4 words and ask them to remember the same. In a few minutes, ask them to recall those words again. Ensure that the patient has heard, understood, and retained the 4 words. Make him or her repeat the words immediately and to correct any errors. Then he or she is asked to recall the words after 5 minutes, 10 minutes, and 30 minutes. To eliminate any possible mental rehearsal, interference should be used between presentation and recall of the words. Normally, we can give 4 words like chhata, phool, ghadi, tasveer, या फिर मछली, lamp, रुपया, ताश. Normally, person accurately recalls 3 to 4 words after 10 minutes. Even after giving verbal cues, improvement in the performance after 10 and 30 minutes may be seen. But in patients with dementia, they cannot improve even after giving verbal cues. These are my references.
Second last slide. For this. So this new learning ability measures what? New learning ability measures what?
The patients.
Unmute, sir. Ask his comments.
Sir, he's unmuted.
Huh?
Unmuted.
Ask his comments. Well, Any questions, comments from the floor? A very important topic, and this we do it day in, day out. And most of the patients, rarely any of them, any of the patients might not require it. And this is supposed to be an expertise of mental professional environmental functions. This is what differentiates us from medicine colleagues and neurology colleagues. So, any doubts, comments, and questions to the audience?
Are we audible?
Hello, yes. Can you hear me?
Okay.
Hello.
Clear it.
You can ask any question which does not have an answer, which does not end with yes or no answer.
Open-ended question. Qualitative evaluation को open-ended question से कैसे? जो आपको evaluate करना है उस बारे में छोड़ना। should be focus on examination होता है ना? Mental examination में you will have to ask an open-ended question. Without the elicit. If you want to you are assessing a plea, you want to recall, you don't need ability. So that is not an open-ended question. That is a focused question. The patient has sustained attention. तो टेस्ट कर तो सारे तो ओपन-एंड क्वेश्चन मतलब मेंटल स्टेटस एग्जामिनेशन में आ गया मतलब यहाँ पे कहाँ बोला लैंग्वेज में कहाँ बोला कॉम्प्रिहेंशन में बोला
सर spontaneous speech.
हाँ स्पॉन्टेनियस स्पीच इज जब आप उसका कॉग्निटिव इवैल्यूएशन करने से पहले ही आप हिस्ट्री दे रहे हो और मेंटल स्टेटस करते हो वही पे आप स्पॉन्टेनिटी देखते हो इज पार्ट ऑफ योर मेंटल स्टेटस एग्जामिनेशन लैंग्वेज का पार्ट भी तो ऑब्वियसली स्पॉन्टेनिटी कितनी है and then you want to subsequently test more than you test those behaviors palatals जो FAS टेस्ट है FAS टेस्ट का कोई हिंदी एडेप्टेशन भी है
Sir, Hindi adaptation.
so Hindi adaptation is ka pa ma test so ka se pa se ma se and but evaluate the scoring is same and the time duration is also same. But why you have kept new learning ability at the last? What it tests new learning ability? The last video, last video, what part of the memory would it assess?
So recent memory.
Huh?
Recent memory.
आप चले जाओ slide पे new learning ability what does it assess recent memory
Recent
parts
memory.
of in registration would assess your immediate memory and then recall will assess your recent memories so new learning ability is in form of verbal that it can be also visual memory जब आप objects दिखाओगे कि और फिर आप कुछ पा दोगे फिर कुछ visual component या auditory component इस वाले टेस्ट से होता ही है serious
Remote memory में एक चीज है, the other things which you ask are auto-evaluating. Okay, शादी कभी first job ये वो, आप कहाँ पैदा होते हैं not an auto-evaluation. It's something that the patient may or may not have heard from others. वो एक मतलब how we can take it as remote memory, लेकिन it is not something that is जैसे बाकी चीजों का है वो मेरा मेमोरी है, ये मुझे किसी ने बोला वो वाला मेमोरी है, लेकिन ना तो जरूरी नहीं कि हर पेशेंट बताए या हर किसी को पता हो अगर नहीं पता है तो कैन नॉट से कि ये उसका मेमोरी का लैप्स है शायद पता ही नहीं
So if some patient says that some patient has disorientation to only person, time place ठीक है, तो फिर क्या interpretation? Patient आया कि जी this is right time, this is Madhu Pradesh Hospital, I'm sitting in security department. I don't know who's it coming. It's only disoriented to person. So what is that? Psychogenic causes clear cut. Either person is having some misidentification or psychogenic amnesia, which is related to the person only. वो सब फिर उस तरफ चलेगा. How will differentiate apraxia with aphasia? You're saying कि lot of apraxia भी आपने एक possibility डाला है, तो apraxia को aphasia से कैसे differentiate?
Sir, in apraxia,
और अगर naming
Sir, in
या
apraxia-
language में apraxia है तो
for example, it will ask the patient to blow a candle. So, sir, he might understand. He will understand it. He will comprehend it that he has to blow a candle. But to the process to blow a candle,
then that is different. That is a motor apraxia. अगर language apraxia उसको फिर हम language aphasia से कैसे differentiate? ये कहाँ से लिया था ये apraxia वाला जो possibility थी? Generally what I my understanding was all these apraxias in this context are known as aphasias. So it's very very difficult कि आपका सारा चीज intact है and you're not expressing the language in any domain because of apraxia. So we would call it aphasias only, more or less. Otherwise clinically तो बहुत difficult है ये जब आप assess करते हैं language domain तो language domain में सबसे पहले assess क्या करना चाहिए? अगर हम स्पीच की बात नहीं करें, लैंग्वेज की बात करें, सबसे पहले कैसे करना चाहिए? Yes, comprehension. Comprehension is must. That is in pointing commands and yes no commands. उसमें आपको सबसे पहले आप comprehension दिखेंगे जो चीज गलती करते हैं, comprehension assess नहीं करते. Then you assess naming, है ना? And then you go to other domains. So then आप बाकी domains में जाते हैं. Fine. So which is the most common aphasia? Fine.
anomic.
Because you see the table, naming सब में impaired. So any aphasia we present as anomia. And repetition will be impaired in three kind of aphasia.
Sir, pure word deafness,
Basically pure motor, pure sensory,
sensory.
and conduction. यही repetition impaired. Transcorticals में impaired नहीं. There are few basics. And attentional assessment is very important. अगर attention ही गायब है patient का तो आपको बाकी आप cognitive assessment कर ही नहीं सकते. So उसका interpretation करना बड़ा मुश्किल है. You have to say कि patient is not attentive, will not be able to do the cognitive assessment. We'll plan it some subsequent assessment. We'll plan it again. That patient might have a better attention capacity. Okay. It turns question नहीं. सब करोगे सारे सबके साथ स्पीचर Did you understand?
So first we'll start with the levels of consciousness. Then for orientation we'll take time. We'll check for time, place, and person. And then for attention, we'll do this digit repetition test. And for language, we'll start with comprehension, then naming, then fluency. And for memory, we will start with first of all with the new learning ability, then the rest.
Should there was some comments? No questions. हाँ ऐसा है मैंने बोला कि एंटीबॉडी इज बहुत कॉमन रिपोर्ट्स लॉ क्या है but reports law क्या है
But in brain injury, the research will go first, then the
उसको एंटीबॉडी रिकवरी नहीं कहेंगे इसलिए एंटीबॉडी अमनीसिया रिकवरी अमनीसिया क्या होता है इवेंट इवेंट हुआ इवेंट के पहले की मेमोरी गई तो रिट्रोग्रेड इवेंट के बाद की मेमोरी गई इवेंट के कंटेक्स्ट एंटीबॉडी I want to say that first recent goes, then the immediate goes, then recent, and then the remote memories are more consolidated. The last so that is the only thought. They are more consolidated, they are more widespread, they are more secondly more widespread behaviors. The immediate memories are they are only located in the medial temporal lobe structures. So जो damage होता है hypoxic damage सबसे ज्यादा होने होता है उसे सबसे पहले होता है exception that's what's good. Okay, so I think yes.
helping organic and psychosocial prevent malingering. यहाँ पे तो वैसे जेल के पेशेंट नहीं आते लेकिन जेल के पेशेंट में काफी कॉमन होता है कि मुझे कुछ याद नहीं आ रहा है so there this kind of test can really yeah like, it is very obvious that they are
And coming to the
so nice okay.
so I think you have to master all this because this is something which will differentiate you. Can't have a very casual, layman kind of an evaluation, specifically in higher. You have to master this and put it across. Why I'm telling you, patient came to us with confusion. In a very subtle manner, we asked the patient, "Do you remember the family members?" She said, "Do you remember the time? What is the time?" She said, 11 a.m. Absolutely fine. We then didn't evaluate that subsequently. No MRI, CT, EEG, nothing. Clear-cut psychological. So we have to, what is like as Professor Jimmy said, antegrade amnesia, autobiographic memories क्या होती है. So autobiographic memories, dissociative amnesia में कैसे impaired होती है. So once we are very very clear with all these, we will be able to answer those and then we will be able to diagnose those without going for all those EEGs, MRIs and attitude. This has to be repeatedly read from various sources. Stephen Black is just an, I would say, reference source. There are a lot of other sources who are very clearly given. Lulier, Nebraska, neuropsychological battery, LNMB, which is given very vividly in detail all these phenomena. Various other ways to test these. So LNMB is a very good reference source. If you want, I can share the book, the material. But that's a must. So you'll not be only sticking yourself to templates or sticking to only Stephen Black. Stephen Black has also examples, and the techniques to assess are also very limited. You need to go for other resources, and then you'll be able to master all those tests. And this is something which differentiates. MRI might come normal. Structural abnormalities, even in 3-test MRI, relevant much later. Functional level, you can still tease it out with frontotemporal issues are in. Patient might be going to dementia, which are not clear in the video. So this is what differentiates us from the others. Very important. I think presented well. You make slides more colorful. And the good thing was you have presented those Hindi questions. That attempt was very good. But you can make it even more interesting, catchy. You can put a lot of videos doing those examinations, even to your friends. And then you put those videos and play those videos. So it will actually be more helpful for the newcomers. Thank you.